The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you. Hope everybody's having a great summer going into the fall months, one of my favorite times of year. I want to apologize first off. I haven't recorded podcast weekly like normal, and I apologize. One of the big reasons that basically since the middle of July, I have been on the road nonstop, came off vacation and have been traveling with my primary job and FlightBridgeED review classes and things like that, where I've only been home prior to this last couple of days where I've had a 4 or 5 day stint. I've only had maybe 3 or 4 days home in the last 3 weeks. So it's been very, very busy, very difficult to obviously record something. So today what we're going to do is we're going to record a podcast based on a new study that just came out. I think it's fitting that I make a response on this. Obviously, I'm not the go-to expert on these things, but I do think that I have a good understanding, and I have looked at this from the perspective of being very objective. I have called and talked to my good friend Mike Abernathy, Dr. Mike Abernathy, and had about an hour phone conversation with him on this subject. So I feel like I'm pretty well versed. I've read this study twice. The first time I read it, I just kind of skimmed through it, and I got to thank my good buddy Dave Olvera, the go-to subject matter expert on airway management that I highly respect, and I think he's highly respected around the world for his efforts in progressing our knowledge on airway management, RSI, and all the things that we can do to better our success and better our patient's outcome, right? That's obviously the big thing. And so we're going to talk about some of those things regarding this study specifically, but things that we can learn. I think it's really easy to look at the study and kind of look at the name, read the name, and automatically pass judgment and say, oh my gosh, and have a knee-jerk reaction. I honestly think that was my initial response when it was forwarded to me by Dave, and I actually, it was pretty funny. I emailed him right back and I said, hey, warn me before you send me something that kind of profound with such a powerful title. Obviously, a title is everything, right? That's what draws the reader in. And so the title of this article is called Hemodynamic Response After Rapid Sequence Intubation with Ketamine in Out-of-Hospital Patients at Risk for Shock as Defined by the Shock Index. And there's some very notable names on this study. I'll name a few. Obviously, I will put this study in the show notes, and you can go and read it. And I highly encourage you to read this multiple times. But Cliff Reed is probably the biggest one. We know Dr. Cliff Reed is a very powerful force in the FOAMed movement. You've probably heard him speak at SMAC. We have Dr. Brian Burns. So we have lots of different people on here that are very well versed and have a very high reputation worldwide. So, this study carries some weight to it. So what does this study look at? What's the question? Remember our podcast we just did on looking at a study and breaking it down, not just taking the conclusion and reading the abstract, but looking at what they're trying to accomplish and then making assumptions or making hypotheses based on their data. How strong was their data? Were there any holes in their data? How relevant is this to our current practice? All those things we have to kind of look at. So what is the big question? The question is, when ketamine is used for rapid sequence intubation, how do the resulting hemodynamics differ when patients with or without risk of shock are compared? So how are they compared? They're compared based on a shock index. Well, what's a shock index? A shock index is basically just simple division. We just take their pulse rate and we divide that pulse rate by their systolic blood pressure. So an example, if we had a systolic blood pressure of 72, and we'll say 72 by palp, and we divide that into a pulse rate of 75, we have a shock index of 1.04. If we take a blood pressure of 82/32 and we have a patient that is a little bit tachycardic at 130, we have a shock index of 1.6. Another example, if we have a blood pressure of 89/40 and we have a patient that has a heart rate of 54, we actually have a shock index of 0.6. So what is good and what is bad? And that was one of the big factors in this study, is looking at a shock index and identifying, does a shock index of low, is there an issue or change when ketamine is given? Or is there a bigger change in patients that had a high shock index? And we know that high shock index patients, or I should say any patient that's decompensating, that is having hemodynamic collapse, we've taught and we've learned over the last few years that ketamine is kind of that go-to medication. It really optimizes, your blood pressure, your heart rate, and things like that. And we also know that we kind of try to limit our ketamine use and really think about it before we have a patient in front of us that has a hypertensive type of bleed. They may have a traumatic brain injury, and they have a hypertensive shift in their blood pressure, things like that. We try to stay away from ketamine. So what is a shock index that we have to worry about? Well, a shock index of 0.9 or greater in the ED, or I could say pre-hospitally, I would assume that would translate pre-hospitally, predicts increased mortality in trauma patients. If we just utilize the blood pressures and the pulse rates that we just used for the example, we said 72 by pulse of 75 gave us a shock index of 1.04. Well, that would be a high shock index. That would be a very sick patient. A blood pressure of 82 systolic, so 82/32 with a pulse rate of 130. We know that any patient that has a tachycardia, right, that is a normal compensation, normal response. We want that, but this patient has a shock index of 1.6. So again, a higher shock index. So any patient with a shock index greater than 0.9 shows or predicts that they have an increased mortality if they're a trauma patient. So why are we intubating these patients? And what did this study look at? Well, the first thing we have to know about this study is this study was an observational retrospective study. So it looked at past data, past patient contact. And so, those studies are good to a point. I think it can bring up other great questions where we can do other studies based on kind of that data, because that data is raw. There was no factors going into, nobody knew this study was going to happen. But I also think that there's obvious things when we get further in this podcast that I can point out that kind of make this study kind of weak in my point of view. So if we think about this, and if you have this study in front of you while you're listening to the podcast, you can go to page 3, and you can see at page 3 you have table 1, and table 1 is basically the demographic data. It looks at the different patient age, it looks at estimated weight, it looks at Glasgow Coma Scale, all those different things. And one of the things you can see is when you get down to intubation reason, high index, so high shock index with threatening airway, so a patient cannot protect their airway, that encompasses 55% of the patients. So 55% of the patients were intubated just solely based on that criteria. So when would we use ketamine, right? We've learned, and you've learned this probably through my podcasts. We've done 2 podcasts, one where I did it by myself and the other one with Dr. Mike Abernathy, where we talked about when ketamine is a good option, right? And I think we have to remember that ketamine has multiple properties, and that's what's so cool about it. Really works in lots of different ways. But one thing that we do know is that ketamine will optimize or stimulate your central nervous system, and it will optimize and increase your blood pressure, and it will increase your pulse rate. And in a patient in shock, that can be a good thing. That can really buy us some time. It can optimize perfusion during those states where they may be hemorrhaging, they may be not perfusing adequately enough, whether that's based on hemorrhage or other reasons. And so ketamine is a great medication in that regard. And we know that other medications that we've used in the past, etomidate, or if you even look at propofol, those medications have a bigger kind of surge as far as dumping your blood pressure. So they don't optimize your central nervous system. They don't optimize sympathetic tone like ketamine does. And that's why ketamine is such a good medication in those patients. I've used ketamine quite a bit in that subset of patient, and kind of yet I have not had a patient respond negatively. Now that doesn't mean that I evaluated their shock index. I'll be honest, I didn't. That's something I'm going to look at kind of a little closer. They may have fallen below that shock index of 0.9. But when we look at this, what is kind of our current kind of thoughts on RSI? Well, one of the big paradigm shifts that we've seen, and I've seen this over the last 5 years, is most companies have kind of moved away from fentanyl use as a pre-induction medication. Now, as we all grow in our knowledge base, and we all grow and our careers kind of evolve, I think it's really important not to be steadfast in our kind of thought process. And I think this study kind of reminds me of that I'm very strongly opinionated based on obviously clinical practice, what I've seen, what I've read, who I've talked to as far as doctors that I highly respect. But we can always learn something, right? And I think we have to always kind of think about it from that perspective. So when I think about fentanyl, if you've listened to this podcast long enough, you know that I'm very passionate about treating patients' pain, and that intubation, putting a blade in somebody's mouth, lifting up, that is highly, highly painful. I can't stress that enough. And that putting them on the mechanical ventilator and having this plastic tube in the back of their throat is also highly painful. And so we have to treat their pain after we intubate them. But we also have to realize that, the stuff that we may read in anesthesia literature, or things that these anesthesiologists or these CRNAs do in the operating theater, is kind of different than what we do. We have highly unstable patients most often. We have a very broad environment. And so a lot of times that doesn't translate. One thing that we have seen, though, is these companies have pulled that back, and they've limited those doses, those pre-induction doses. And we saw that for a long time, we were giving 3 mics per kilo prior to RSI, and then we would then give our induction medication. Back then it was etomidate, and then we would give our paralytic. And that has kind of changed, where we saw that pulled back to about 1 mic per kilo. And then just recently, I know 2 of the largest companies have actually pulled that back altogether, where they have taken that out of the guideline. They've taken that out of the protocol, where fentanyl is not used as a pre-induction medication to treat pain. Now, again, I'm very strongly opinionated on this, and I think, I can just have a knee-jerk reaction, and I can say, well, that's crap, or that doesn't even make any sense. Those are closed-minded people. But once I start reading something, and I think that's the key thing you have to do, is you have to investigate this. You have to find out why this has happened. If you think about a company the size of Air Methods or PHI or Air Evac, they have lots of medical directors. And whether we want to realize it or not, or we want to accept that, they have MD behind their name, and these gals are highly intelligent. They have a lot more experience than we do, and there's reasons why they make these kind of assumptions and they pull back. Granted, some of that may be just opinion. Maybe that's a bad kind of incident on, that they've witnessed or they've experienced themselves. But most often I could say that there's a reason behind it. One of the things that I've evaluated is that we have changed our treatment, right? Most programs now in the last couple of years have moved away from etomidate. Obviously, that's still in the guidelines as an option for RSI and for that induction medication, but we've moved away from that, and most clinicians that I talk to, they like ketamine, and we know that why we like ketamine. Ketamine is a great medication utilized in lots of different ways. And so I guess my question is, we're giving fentanyl in the past to blunt the sympathetic response that we see with intubation, because we know that sympathetic response, that pain associated with intubation, causes possibly a raised ICP. And we know pain always is the kind of the first culprit that we want to address as causing ICP increases. But remember, ketamine has multiple kind of layers to it. We can give it for very small things as an analgesic medication. right? At that 0.1 to 0.25 milligrams per kilogram, that's kind of like a 10 milligram dose. That's where we hit those pain receptors. We hit those pain receptors, though, kind of in a different way. We don't target those pain receptors. We target those based on the thalamic and limbic system in the brain. And so we deal with perception and disassociation and muscarinic receptor response and blocking that response. And if you move all the way up to maybe a sedative dose of 0.5 to 1 milligram per kilogram, that's where you have partial disassociation. And then in RSI, we go all the way up to completely disassociated. And that's why we give a 1 to 2 milligram per kilogram dose. So I could argue now, thinking about this objectively, that we're giving such a large dose of ketamine, 1 to 2 milligrams per kilogram, which really isn't that big of a dose, that we're blunting that pain. We're blunting that sympathetic response. We're blunting that potential pain response. And so is fentanyl needed? And the longer I kind of read on things and think about this, if you're using ketamine, is it needed? And I posed this question to Dr. Mike Abernathy, and he thought, that's a great point. And that's a great thing to kind of look at. I don't know what the right answer is, but looking at it objectively, that's something that we can definitely look at. We have to also realize that fentanyl, if we're going to give a 1 mic per kilo dose, that's really doing nothing as far as blocking that sympathetic surge. A dose of 3 mics per kilo is needed to actually block that ICP, that pain response associated with that sympathetic surge. So we really need to be giving that 3 mic per kilo dose in that regard. And so obviously most companies have pulled that back, and that's not happening. We have to also remember that when we have these severe trauma patients, these patients that fall under that high shock index, right, greater than 0.9, probably the only thing that's keeping them going is sympathetic surge, right? That's the only thing that's keeping them alive is sympathetic surges. So if we give fentanyl, which is really, really good at blocking that, are we now blocking their compensation? Something to think about. These are patients, right, that are highly, highly sick, about to die. I'm not saying all patients, right? But if you think about a patient that is hemorrhaging, that has massive trauma, they've depleted a lot of those catecholamine stores. The more they bleed, the more they hemorrhage, those stores get depleted, and we have nothing to kind of trigger when we're giving those medications. And so if you blunt that response, and that's all they have left, that, regardless of how you feel about fentanyl, we know fentanyl is really good at maintaining a good blood pressure when you give it, and you're not going to see this big drop. That right there could cause a patient to die. So it's something to kind of consider. And it's something I'm looking at completely different than I used to. One of the things this study said that was interesting is it says in patients with low shock index, so remember that's less than 0.9. Another interesting thing is in patients with low shock index, the systolic blood pressure increased and remained elevated after the second and third reading after ketamine was administered for induction. But that's a low shock index patient. So I think it's important to understand that when we have a low shock index patient, why does the blood pressure remain high? The blood pressure remains high because ketamine does what it's supposed to. It's supposed to optimize the central nervous system. Well, it can only do that if it has the ability to do that, if it has the ability to trigger and sense and grab onto those catecholamine receptors. Well, if a patient is in a high shock index state, right, they've hemorrhaged everything out, they're in a state where they could decompensate any second and die, you give ketamine, it's not going to work, right? You're not going to have those catecholamines to kind of grab onto. And so why in those low shock states did we see patients have optimization of their central nervous system? And why do we not see that based on this study in that high shock index patient? One of the things to kind of realize, and you can look at this on page 6 of the study, it says in vitro, ketamine is negatively inotropic when applied directly to cardiac muscle. However, in vivo, it is sympathomimetic in patients with an intact autonomic nervous system, acting to release centrally mediated catecholamines and inhibit their reuptake. This mechanism accounts for the hemodynamic stability in ketamine. So in that high shock state patient, that high shock index patient, that isn't happening. You don't have those catecholamines. So that is why potentially we're seeing a reduction in blood pressure after ketamine administration. So what did this show? In patients that had a high shock index, there was no increase in heart rate compared to a low shock index patient, where they saw a bump in heart rate by 20 beats per minute that was sustained again after that second and third evaluation of vital signs. So in that high shock index patient, again, because there's no catecholamines, because they can't grab onto anything and act as that sympathomimetic medication, then you don't have that response, right? And that's a bad thing. So now let's look at the data. Let's look at the sample size. The sample size, again, this was a retrospective observational study, right? So this was not randomized. They didn't control the data. They didn't control kind of all the different outliers that we're going to talk about here in a second. But there was a total of, I believe, 112 subjects that were intubated. And so 31 of those patients were considered a high shock index patient. So only 31 out of the 112. And out of that 31, 8 of them, so 26%, which is a pretty big number. So 8 of the 31 that were considered a high shock index patient had hypotension after ketamine administration for induction. So what does that mean? Well, again, if we just read that and we didn't investigate, we didn't look at all the data, we could easily make an assumption that ketamine is bad in those hypoperfused patients, in those very sick, hemodynamically unstable patients. And I think this is where reading a study and really looking into it in depth is very, very important. So is there any possible issues with this study? Is ketamine to blame, or is there other variables that can cause a drop in hemodynamics for these patients? If you look at another couple studies, or one specifically, Hefner et al. Studied ED patients with and found increased risk of hypotension within 60 minutes of onset of intubation and ventilation for their high shock index group, also comprising patients with a shock index greater than 0.9. So, right, same variable as far as shock index. Both of these studies used etomidate and propofol as their induction agents. As far as we are aware, ours is the first study to investigate the association of shock index to out-of-hospital induction or in association with ketamine. So basically, in this study that they did with propofol and etomidate, they still had the same results, right? These high shock index patients, they decompensated. They had hypotension. Again, is there other variables involved? So one of the interesting things when I started looking through this is I wanted to kind of identify, all right, well, what was their data? And you can go to page 4 of this study, and it's table 2, and it goes into painful procedures, like what was going on. Was there a pelvic binder? Was there a limb splinted? Did they crack the chest? How many attempts at intubation, right? Was there any issues there? And then it goes into pre-induction medications, right? So those pre-induction medications would be things like fentanyl. They have morphine, they have Versed, and they have ketamine. And so I started looking at that, and I thought, well, that's interesting, right? They're giving a pre-induction medication, and then they're giving ketamine, and then they're giving a paralytic. So, is there any data to show that, yeah, they got a pre-induction medication like morphine? Well, that kind of surprised me. And so I looked at it, and in the high shock index patients, 13%, 4 patients out of the 31 in the high shock index kind of group got a morphine dose, and that morphine dose was based on a milligrams per kilogram. So the morphine dose was 0.13 milligrams per kilogram. And so again, I started thinking, well, we know morphine is not the best medication. We know, especially in a systolic blood pressure less than 90, we're always going to kind of think about that. And I know we have fentanyl now, and we don't really utilize morphine like we used to, but we also know it's got a huge histamine release component that also causes issues, right? And we see that with decompensation, with a drop in blood pressure. So, I could argue, well, is 4 of the patients, 4 out of the 8. So there was only 8 out of the 31 in the high severity index or high shock index criteria, right? Remember, there was only 31 patients that fit that, and 8 of those had a hypotensive event. Well, we had 4 patients that were given morphine prior. Could I say that 4 of those patients were the 8? I could. Do we know that data? No, we don't. Could it be 4 patients that did not have hypotension? Absolutely. But I think it raises other questions. There was also 19%, so 6 patients got Versed in a pre-induction medication dose. And so that dose was 0.08 milligrams per kilogram. So again, 6 of those patients out of the 31 got Versed prior to any induction medications at pretty much a tenth of the dose. And we also had ketamine given at basically a pain sedation dose of 0.4 milligrams per kilogram. 48% of all the patients got ketamine at that tiny little dose that we give for pain and sedation. 15 of the patients, so 48%, 15 out of the 31, half of the patients got a pre-intubation dose or pre-induction medication dose of ketamine. And then they move into the induction medications. They had patients that were inducted. They show fentanyl, right? And they basically, in the high severity subset, there was 0. But as far as ketamine was the primary medication, right? So ketamine was given, and that was significant. So that was the primary induction medication. And then, is there a difference in the paralytics? Well, we've done podcasts on the paralytics. And so I think, kind of recap what I'm saying here is that we have a pre-induction medication of fentanyl, morphine, Versed, or ketamine at a small dose. The big 2 that I'm concerned about with this study is morphine and Versed. Did that cause any problems? Well, we don't know, right? We don't know. Again, between those 2 medications, that accounts for, 33% of the 31 patients, right? 33% of those patients got either morphine or Versed. Another 48% got ketamine at that low dose. So we don't know if that aided in or caused a response when they were given a larger dose of ketamine, right? We also, again, know that paralytics are not created equal, and we've done a couple podcasts on this subject. You can go to the website. You can look up the Passive Oxygenation podcast. I talk about the study by Scott Weingart, Rich Levitan, where they looked at the paralytics. They compared them as far as was there a difference in each one, and they noted that there was a 2-minute difference in desaturation when given sucks over rock, right? So rock was superior in that regard. And we also know that John Sackles and his colleagues did a study on traumatic brain injury patients. And we saw that highly severe patient with traumatic brain injury had a almost 50% increase in mortality when given succinylcholine. So, when we look at that from that perspective, did that cause a decompensation? So if you look at the study again on page 4 and you go down to the bottom where it says induction medications and it goes to the paralytic side, you can see where it says rocuronium. 77% of the patients that were in this high shock index subset, so 77% or 24 of the 31 patients were given rocuronium, right? And I like that. That's good. That's one positive. However, 23%, the remaining amount, or 7 patients, is given what's called succinylmethonium, and that is kind of used in Europe, but that is essentially succinylcholine. And so, again, what we know about succinylcholine, did that cause any adverse issues with these patients and cause a worsening decompensation? Again, I can't answer that question, but I think it's a valid question to ask, and I think it's something that we could maybe design a study that focuses strictly on utilizing the same medications. What I would love to see is you give no pre-induction medication. Basically, they go from all of the things that we do in preparation, right? Positioning, preparing, positioning the patient in a way that you're going to optimize their view, whether you're an adult or pediatric, passive oxygenation, continuous apnea oxygenation throughout the entire procedure, so on and so forth. So do all that the same, then give your ketamine, then give your paralytic. And I would love to see, rocuronium given in that regard. And I think that isolates ketamine. It isolates it and then utilize this high severity shock index and say, all right, ketamine's your induction medication. We're given rocuronium. We know that there's 2 studies that have shown superiority over succinylcholine, so we're getting the succinylcholine out of the way. We're just strictly focusing on ketamine. So that would have to be a randomized type of a study. And I think that there's definitely data based on this study where we could look at that and argue that that would be a great study to kind of evaluate. So all of this kind of to kind of bring home some take-home points. I'm not sure if this is a valid, concrete study that says, in patients with a very high shock index, we need to stay away from ketamine. One of the things we have to remember is we only have one other drug in most guidelines for induction, and that's etomidate. And we don't do crash airways, right? Crash airways are kind of looked at from a lot of people's, doctors, companies' perspective as unethical. I'm not saying I haven't done a crash airway in my career, but we know that that's not the best option, right? It's quick as we can drop your paralytic, you can drop a little bit of induction medicine, whether that's etomidate or ketamine, right? So we don't want to do that. So let's talk about some take-home points here. I'm not really sure that this study proves that ketamine is the culprit. I think that there's a lot of things that I've brought up that we could look at from another perspective, maybe studying this focused, like I said. It very well could prove that ketamine is not a valid medication in that kind of regard. One issue, though, we have to remember is we only have so many medications at our disposal. We have to give some type of induction medication, whether that's etomidate or ketamine, right? We're not going to give Versed. Versed is going to cause the biggest drop in hemodynamics. And so you got to pick one, right? We don't do crash airways. Crash airways are looked at now as kind of unethical. It's always been kind of on the borderline. Some people have said that, absolutely do not do them. Some companies say, yeah, in these kind of circumstances, it is all right. I'm not saying I have never done a crash airway. I have, but it's been a long time. So we kind of have to pick a medication, right? We got to pick something. The other issue is this is, again, an observational versus randomized. So this is an observational retrospective look at, a bunch of charts, 112 patients, very small sample size. I think looking at this from a larger sample size is going to validate the data a little bit better. I think having a study that focuses on consistent pre-induction routine can isolate if this is a ketamine issue or not. Maybe it's all medications. Maybe any medication in those high severity kind of subsets, right? Those patients with a greater than 0.9 shock index. No matter what you give them, they're going to have an issue because, again, they only have so many catecholamines left over. Can we isolate the paralytic? And again, maybe isolate the paralytic, isolate the induction medication, give your ketamine and your rock in a randomized trial. So what's the answer? The answer, guys, is not kind of written in stone. This is kind of an objective thought, but I think when you look at this, and this is something that I've talked to a few people about over the last couple months. Dave Olvera is one of them, Alan Wolf is one of them, and Dr. Mike Abernathy is one of them. Just to name a few, is we see patients that arrest after RSI. And when you look at the chart and you look at the data, everything has been done really, really well, but patients arrest. So why is that? Is there something we can be doing differently? One of the data points that I think Air Methods has done really well with all of their airway research, and again, I'll give credit to Dave Olvera and Alan Wolf and David Stuemiller and Dan Davis and Charles Swearengin, that all this data is being looked at closely, and it's not about our opinions, it's not about what we've done in the past, it's about looking at the data only. And they've identified quite a few little cool things we need to change where we intubate, right? Intubating in flight, intubating in a setting where we're cramped, we don't have the ability to move around, we don't have the position, the ability to position our patients the way we normally would. That limits our success. And they've noted a 12% basically drop in patients that were having their SpO2 maintained at a normal range, right? So they were having a 12% increase seen by this data in desaturation when patients were intubated in flight over a stationary kind of setting. And so one of the big paradigm shifts is to teach, it may be better for our patient to sit on scene for an extra 10, 12, 15 minutes if needed to secure that airway. It may be better to do that in the ED rather than get them in the aircraft and doing it in flight. We have more control, we slow down, we take care of the little things. So that is one of the big things. And then the other thing is not to just rush in RSI patients, is to resuscitate them. Think about resuscitating them. Think about optimizing their hemodynamic ability to compensate. And so most aircraft, or I should say a lot of aircraft now, are carrying blood, right? Whether you're carrying packed red blood cells or you're part of the PAMPER trial, if they fall under that high shock index, I would argue that they would be a candidate for blood or plasma, FFP, immediately. And so starting that blood early, you can still manage their airway with different techniques. If you want to kind of consider some of those techniques, go back to the Damage Control RSI podcast where I talk about that. But if we resuscitate, we take 3, 4, 5 minutes and we start those interventions. Even if we have to maintain and manage the airway with a BVM and a PEEP valve for that 5 minutes, and we get blood started, we get some volume started, and we start resuscitating them first, and then give them those medications, I would argue we probably would have less patients kind of decompensate, right? We have to think about what we're doing. We can't just rush and start managing the airway in an advanced kind of manner with intubation. We need to focus our attention on resuscitation. So I think that's one of those things. And again, if you think about your ABCs, we know that paradigm has shifted as well. It's shifted in a lot of areas, but we kind of now look at it from circulation, right? We've got to have circulation. So focus on the circulation, focus on optimizing hemodynamic status, your cardiac output, deal with your airway, manage your airway with BLS procedures, whether that is passive oxygenation with cannula, non-rebreather. If their SpO2 is less than 93%, putting a BVM together, utilizing a PEEP valve with 10, right? The 10 of PEEP is the new 5, so utilizing 5 to 10 of PEEP. Don't be afraid to go to 10. Putting your end-tidal CO2 either via nasal cannula on the patient or on the BVM, and providing good BVM ventilations, placing an NPA in both nostrils. Doing those things while you're resuscitating them for a few minutes, and maybe our patient outcomes will be different. Maybe they won't, right? Some of these patients are so gravely ill, blunt and penetrating trauma, that it's not gonna change. But we don't know until we try. And so I think the big focus needs to change on stopping, slowing down, managing that patient, resuscitating them, and then RSIing them, not just rushing to secure that airway. So I hope this podcast kind of was enlightening. I really encourage you to read this study multiple times. If you have any questions, feel free to email me at eric.bauer@flightbridgeed.com. Would love to talk about this. And again, I'm going to be putting out another podcast next week. So be looking for that. I'm going to kind of focus on some oxygenation stuff, some stuff we've done in the past I'm going to redo, and then we're going to do kind of a big series on trauma, on packed red blood cells, kind of relook at the proper trial, relook at the PAMPER trial, look at what we need to do in trauma to really try to optimize our care and get them to the trauma center. So until next time, again, thank you so much for the following, and email me if you have any good cases. Check out our website for any review classes in your area, and I will talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.